Hello, everyone. Today, we're going to talk about one of the most important clinical skills in psychotherapy, counseling, and behavioral health: how to conduct a strong differential diagnosis. Not by guessing, not by simply matching symptoms to a checklist, but by using abductive reasoning. Abductive reasoning is often called inference to the best explanation. It asks, given all of the available evidence, what diagnosis best explains the full clinical picture? This is different from deduction, where we apply a fixed rule, and different from induction, where we generalize from repeated patterns. Abduction asks, what is most likely true? Good clinicians do this constantly. We gather data, we compare possibilities, we revise our thinking, and we avoid premature certainty. Let's walk through a practical structure for doing this well. Step 1. Start with symptom clusters, not labels. Many clinicians make the mistake of rushing toward a diagnosis too quickly. Instead, begin by organizing symptoms into categories. Think in clusters. Ask, what belongs together? Useful categories include time frame, cognitive symptoms, mood and affect behavioral symptoms, physiological or somatic symptoms, interpersonal functioning, trauma, history, substance use, occupational or academic functioning, medical contributors, spiritual or existential distress, risk factors such as suicidality, aggression, or self-harm. This helps prevent tunnel vision. You are not looking for a label yet. You are building a map. For example, a client reports insomnia, racing thoughts, impulsive spending, irritability, high confidence, and decreased need for sleep. That cluster points us somewhere very different than low energy, guilt, hopelessness, and psychomotor slowing. Symptoms must be grouped before they are interpreted. Step 2. Establish time frame and course. Time matters. Always ask, when did this begin? How long has it lasted? Is it episodic or chronic? Did symptoms emerge suddenly or gradually? What was happening before onset? Was there trauma, substance use, a medical event, relationship loss, job stress? For example, 2 weeks of depressed mood is different from 2 years. Panic attacks since adolescence differ from panic beginning after a cardiac event. Time frame protects against misdiagnosis. Step 3. Generate probable diagnoses. Now begin forming possibilities. Not one diagnosis, several. Create what I call a diagnostic ladder. At the top, most likely diagnoses. In the middle, possible but less likely diagnoses. At the bottom, rule out diagnoses that must be considered. For example, a client presents with concentration problems, restlessness, irritability, and poor sleep. Possible diagnoses may include generalized anxiety disorder, ADHD, major depressive disorder, PTSD, substance-induced anxiety, hyperthyroidism, medication, side effects. Never stop at the first plausible answer. Good differential diagnosis requires disciplined alternatives. Step 4. Ask what best explains the whole picture. This is the abductive step. Which diagnosis best accounts for all the evidence? Not just part of it. The best diagnosis should explain symptom pattern, severity, duration impairment, developmental history, context, and response to prior treatment. For example, is the concentration problem truly ADHD? Or is chronic anxiety impairing attention? Is emotional numbness depression? Or trauma-related dissociation? Is irritability bipolar disorder? Or substance withdrawal? The question is not, can this diagnosis fit? The real question is, does it best explain the full picture? Step 5. Look for comorbidity carefully. Sometimes the answer is not one diagnosis. It may be 2 or 3. But clinicians often overdiagnose instead of thinking clearly. Ask, is this true comorbidity, or is one disorder creating symptoms that mimic another? For example, PTSD may look like ADHD, panic may look like cardiac illness, depression may look like cognitive decline, substance withdrawal may look like generalized anxiety. Do not multiply diagnoses unnecessarily. Precision matters. Let's look at the most common mistakes. Error 1. Premature closure. This happens when clinicians stop thinking too early. They find one plausible diagnosis and stop exploring. Fix, always generate at least 3 alternatives. Error 2, confirmation bias. This happens when we only notice evidence that supports our first impression. Fix, actively search for disconfirming evidence. Ask, what would prove me wrong? Error 3, ignoring medical causes. Psychological symptoms may have medical origins. Thyroid problems, sleep apnea, neurological disorders, medication effects, hormonal changes. Always rule out medical contributors. Fix, collaborate with physicians and obtain medical history. Error 4, ignoring substance use. Alcohol, cannabis stimulants, benzodiazepines, prescription misuse. Withdrawal states. These can mimic nearly every psychiatric condition. Fix, always assess substance history carefully. Error 5, confusing state with trait. Temporary distress is not always a personality disorder. Acute trauma may look like borderline traits. Severe depression may look like dependency. Fix, assess long-term patterns, not just crisis behavior. Diagnosis should never be an act of labeling. It should be an act of understanding. Differential diagnosis is not about putting people into boxes. It is about asking, what is happening here? What best explains this suffering? And what intervention gives this person the best chance of healing? That requires humility, curiosity, and disciplined abductive reasoning. Because good clinicians do not simply diagnose, they think, and they keep thinking. Thank you for being here. If you enjoy content on psychotherapy, REBT, CBT, trauma treatment, and clinical reasoning, be sure to subscribe. And remember, the goal is never just accuracy. The goal is helping people wisely. This video is intended for educational and professional training purposes only and does not constitute medical, psychological, psychiatric, or legal advice. The material presented here is designed to support clinical learning and critical thinking, not to replace formal supervision, consultation, licensed assessment, or individualized treatment planning. Differential diagnosis should always be conducted within the scope of one's professional training, ethical standards, and applicable licensing regulations. If you are experiencing significant emotional distress or mental health concerns, please seek support from a qualified licensed healthcare professional or emergency services in your area.